Good morning. My name is Doug Smith, and I'd like to remind folks the focus of the FiRe conference this year is platforms. In this particular session, the topic is fixing healthcare, which is a track that we've had for about 5 years, and this particular year we're focusing in on reconnecting patients and providers. My name is Doug Smith. I run a firm called W.D. Smith & Associates, and what we do is provide technology solutions to the full spectrum of players in the healthcare market, insurance companies, providers, etc. I'm joined here today on the near left by Garri Jones, who's involved with an organization called Circle Health of Europe, a health services delivery company. And next to him is Nick Hanauer, who is a partner with Second Avenue's Partners and a serial entrepreneur, can't help himself, keeps coming back. Constantine Davlantes is next to Nick, and he's a VP of Business Development for a medical device company called NivaSonix, who we heard about a little bit earlier today. And last but far from least is Sheryl Skolnick on the end, who is an analyst with CRT Capital in New York and a self-admitted critic, Hollywood critic of healthcare and information companies. So before we get into the discussion, let me help frame the discussion a little bit before we get off onto too many tangents, because I think as many people know from previous sessions and reading the newspapers, this market, healthcare, and the systems and everything within it is huge, and it's very easy to get sidetracked by this problem or that problem and not try and focus on solutions that are more systemic. So just in terms of scope, over $2 trillion in the United States are expended in this area. This last year, 2009, was the largest increase on a percentage basis in healthcare expenditures in the U.S. since 1965. This trend has been unabated, the increase year over year. I think most people know that. But the important part is that I don't think we're getting value for it. As the group, when we met over breakfast today, discussed and chewed on a little bit, we're spending an awful lot in the United States for healthcare, twice the next most generous expenditures by other countries, being the UK, and yet by just about any measure, whether it be infant mortality, life expectancy, chronic care condition management, etc., we're not getting value for it. So in short, there's no shortage of problems to look at. Our challenge, and the panel's challenge, is to look at this complex system and figure out how we can move it from a unit pay basis, how we can move it from something that doesn't look like we're getting value for what we're investing, and move it towards something that we get this elusive outcome time after time called health. So my challenge with this group is to try and keep the conversation focused on solutions rather than problems. It's so easy, like going down the highway, going by an accident, a rubberneck, and look at this problem and say, oh, that's horrible. But we're on a different kind of path. We're heading towards solutions. So at various times, and this is an open invitation and perhaps a caveat as well, we may come to a point in the conversation where the group is very energized, and I'll probably bracket those off with the promise of bringing it up this afternoon at 3:45. So stay tuned. If you are particularly engaged in that subject, put it down on your calendars and we'll see you at 3:45. So one other point I'd like to lay out there before I turn it over to the panel is that I think both in legislation in this country, of which there's been a plenty in the last 18 months with the stimulus package and more recently with healthcare reform, there is for the first time a changing type of topology and ecosystem out there, at least in the United States, where there's a tremendous amount of funding, and this amounts to, by the time you get down with the multipliers, hundreds of billions of dollars that are now flowing in the form of subsidies, trying to direct the way the healthcare system is going to be financed, and more importantly, even the way it's going to be delivered. One of the things that seems to be gaining a lot of momentum right now is what's called a patient-centered medical home, and that is a return to the preeminence of primary care and the patient being at the center of the healthcare delivery system instead of the provider. And this is energized in many ways, but one of them, importantly, is that the heart of that is a payment mechanism that doesn't pay for units of service, doesn't pay doctors to be piece workers, but rather pays them on a capitated basis, as it's been called historically, or on a per-person basis, which changes very radically the paradigm for payment and has the promise of changing the motivations and the interactions between patients and providers, and perhaps creating the foundation for a more solid kind of relationship that's based on care rather than how many visits I can produce per day. So having said all that, I'd like to turn it over to the group and ask them, perhaps starting with Garri, do you think this kind of model has legs to it? Do you think this kind of model that is primary care based is going to be the right way to go? And what do you see some of the barriers and promises of it? And perhaps this is also a place where you could bring in some of the differences between the UK and the United States, and maybe we can go to school on you guys.
I think, if we go back 4 years and just talking quickly about the United Kingdom, and we identified 4 years ago sort of 4 areas where we could hopefully help to fix relationships, and we're an employee-owned and a clinician-owned business. Infrastructure, we've built Europe's largest day case centre and probably Europe's finest private hospital. Operations, we operate the hospital pretty well. But the fourth bit, technology, and this point you make about connecting with the patient has stumped us in the UK as much as it has in the US. And I think we have exactly the same issue, which is before we get too far in sort of rolling out our company and how we connect with the patient more, we need to make this decision about the importance of primary care and how we can engage with the patient, whether via the insurer or in our country also via the government, via the NHS, or do we go direct? And I think that's something, frankly, we're dealing with as a company right now and as a UK health. So I don't actually think there's any difference between the US and the UK. The big question is how directly can you get involved with that patient? And once you've figured that out, there may be technology solutions that help. But I think the strategy comes before technology. Okay,
good. Nick, let me ask you, earlier today we were talking about what has come to known as disintermediation. And I think you had some fairly strong views about the roles of insurance companies. I have to, in the atmosphere of full disclosure, let you know I actually was the CEO of an insurance company, but also in provider groups. So I've been on both sides. I'm not going to take any offense by it, but I've asked for your candor on that. What is the role of insurance companies, and is there value they create?
Okay, so yeah, I am, as you know, here representing quite a simple idea, and that is that healthcare in America is broken, and it's broken for one pretty simple reason, and that is that we have allowed insurance to mediate every healthcare transaction rather than the healthcare transactions which are catastrophic. And in fact, 9 of 10, or maybe more than 9 of 10 healthcare transactions aren't catastrophically expensive. And there's there are a couple of very easy ways to understand why this is a bad thing. And I broke the rules and did bring a couple of slides, and I can see one. Can you see the first one? This is simply the flow of human activity necessary for somebody to visit a doctor under the insurance paradigm with a cough and a fever.
Nick, does this light up if you attach a charge to it or anything?
All those red boxes have to do with insurance reimbursement. The yellow boxes are what you have to do to affect insurance reimbursement. And the problem with that is that layers on about 40% more cost for those transactions. That is to say, if you got rid of all those red boxes, those transactions would be much, much cheaper. If you substitute that business model, that employer-paid, fee-for-service, insurance-based business model, with a business model, a direct medical home, where you actually pay the doctor on a retainer basis. You can go to the next slide, please. That's the flow of human activity. That is healthcare reform. And it's actually a bigger deal than that. By the way, we're rolling these clinics out nationally at a price of about $50 a month per person for all primary, preventive, and chronic care management. No fees, no co-pays, nothing. $50 a month. Here's the more interesting part. I'm just going to share some data with you that's relatively new. Not only do you cut the cost of each transaction dramatically, but you totally change the nature and volume of the transactions. So for a Medicare patient, that is to say an older patient, the rates at which the transactions decline for high cost services are these. For ER visits, our patients see ERs 84.5% less often. Hospitalizations go down 88%. Specialist referrals go down 76%. Advanced radiology falls 85%. That's what happens, as Doug said, when you make primary care the center of medical care, rather than a conduit through which patients flow to ERs, hospitals, specialists, and radiology. And so, the great challenge, I think, for healthcare in America is to disintermediate insurance companies from the transactions, the 90% of transactions where they don't belong, and use insurance, which works very, very well for catastrophes.
So it's kind of a wraparound to the primary care services and manage your expenses.
Wraparound is not quite the right thing because wraparound doesn't work because insurance companies have so devalued primary care that if you say to an insurance company today, pull out the primary care and provide me with everything else, they'll give you a $5 a month discount because that's all they think primary care is worth. Mm-hmm. So anyway. Okay,
thank you. Constantine, you are here on the panel representing the whole medical devices industry. I know it's kind of an awesome challenge, but in light of the model that Nick has laid forth, I'm sure there's a role for medical devices, whether it be sensing devices or in the home or on the person. Could you speak to that and where you think that plays a role here?
Yeah, actually, there's been quite a bit of technology already available for a number of years. Telemedicine, being able to monitor a person's heart from a watch, transmitting that through the internet, reprogramming pacemakers over the internet, that kind of thing. The problem is, the implementation of that technology and the availability of it is not that widespread. It's, you'll see pockets depending on where you live. And there's simple things that people can do as clinicians, as doctors, for example. You're starting to see, doctors' websites, being able to transmit securely patient information, patients being able to, schedule appointments online. What's the most frustrating thing we do when you call a doctor's office? If you can even get through, you're put on hold. You waste 20 minutes of your time just trying to schedule an appointment. So not everybody has internet. My parents don't even know how to turn on a computer. But if you can going back to the original topic of this session, bringing the patient to the doctor, it's all about communication. Mm-hmm. So if we can encourage physicians to improve the way they communicate and talk to their patients and have two-way dialogue so that a patient can call a nurse, in the case of Nick's pneumonia example. If I think I have pneumonia, I can log on and click on a checklist of questions that narrows down the possibility, or I can even talk to a nurse live if I don't have a computer. And that goes a long way in streamlining the process.
Well, let me make 2 points or bring out 2 points, because I think in some of the speakers' comments, there's something that's kind of hidden here, and that is electronic health records or personal health records. The density or implementation of those is really lagging. It's lagging throughout the world by and large. But in the United States, less than 20% of physicians actually have electronic health records. So what's happened is the business has been dominated by getting paid. It's billing systems on the provider side and it's claims processing systems on the insurance side, which kind of belies what we're really trying to do here. It's how you get paid. Granted, I'll give you that, but it's not how care is delivered. You're delivering care one CPT code at a time because that's how you get paid. So one of the problems that Constantine didn't bring out is that providers weren't getting paid for telemedicine for a long time. And the evidence is frankly pretty damning. Until up to 2001, there wasn't even a code to bill for telemedicine. So we now have a code, and insurance companies are starting to pay for it, but the devices and the connectivity and some of the care that's delivered by paraprofessionals or allied health people or nurses and technicians wasn't paid for at a level that made it economical. So I think there's a sea change that's taking place. And to get back to this theme of platforms, the stimulus package in this country is really pushing, inherent in is about $18–20 billion, the implementation of electronic health records. So one of the platforms that I think will change a lot of this, connectivity, base of data, sharing of data, is that EHR rollout. Sheryl, I'm sorry, I've taken too much time here.
That's all right. First of all, let me say I'm happy to take the role of the skeptic, okay? And also, again, stepping back, I'm going to say that I'm very enthusiastic about the changes that are taking place in the healthcare industry today. But, as a Wall Street analyst who's covered the healthcare sector for 22 years, and the comment was that, you know, I'm more of a movie critic. I don't build the hospitals, I don't build the systems, but I've seen an awful lot of them. I know an awful lot of the companies and how they're performing and what they're doing and what they're thinking about strategically. And after 20 years of earnings calls and talking about minutia, I'm much more focused on the strategic import of what these companies are investing in, whether they have the vision for the future or not. So that's kind of the preamble that I'll give you. I have a number of issues that I'm going to bring up. First of all, one of the things I did when I was in high school was I worked in a pacemaker clinic whereby over a 300 baud modem via telephone in a cradle with bracelets, we took EKGs of pacemaker patients to make sure that the thing was still ticking. That was telemedicine then. Quite frankly, the watch on the wrist over the internet, the technology is old. All right, that's nothing new. But if it saves a patient from dying, it's one of the most cost-effective ways of monitoring a patient I've ever seen. So, you know, we need to give ourselves some credit. We've been pretty innovative in a lot of ways when it comes right down to it, even without the grandioseness of an ARRA stimulus package or anything else. We've been pretty clever about changing the way medicine is practiced and tracking our patients and some of the most vulnerable among us who need that help. So technology's come a long way, but not that far. The other thing I'll mention is that with the internet, we have seen a tremendous amount of information flowing into the hands of patients. Now that creates a big problem for physicians. You come in as a very educated patient and they don't like you. They don't want to treat you. You know too much. What are you, self-medicating, self-diagnosing? And for the hypochondriacs among us, this has been an absolute bonanza. So if anything, too much information has increased the cost, clogged the system further. That's what the skeptics could say. But at the core of it, an informed patient population about their disease states, about the things that could be wrong with them, about the things that they could and should be doing to improve their own health status, about the details of their health status, can only help the situation, especially when it is paired with financial information about what the true underlying cost of their care will be, so that in conjunction with their medical provider, they can make an intelligent, informed choice and choose the low-cost, high-quality outcome and option, whether it's a hospital, a diagnostic center, whether it's a physician, or any of the above. And that's really where we want to go. So whether you use some sort of encrypted social media or encrypted BlackBerry solution or internet-based or the telephone, that's really, or paper, that's really where you want to go if you're going to involve the patient appropriately. We left patients out of health reform. We left providers, physicians, out of health reform. It's not health reform, it's health insurance reform. And I'll wrap up by saying this. I make a study of what hospitals do most of the time that I'm at work. I think about it a lot. And historically, these guys have been some of the most backward-thinking technology implementers I've ever seen. They've been the most backward-thinking management teams I've generally ever seen, next to the airline industry. They've been reactive. But I'm proud of them today, because whether it's the fact that they know they're losing money on Medicare and we're all aging, and as we age, there's going to be even less money and they're going to lose even more money on Medicare, or we're all going to be uninsured and going to be on Medicaid, they know there's a cost imperative today. They know the only solution is using data-driven solutions to convince physicians to be low-cost, high-quality providers, which, by the way, none of them want to go in front of a malpractice jury and say, I'm a high-cost, low-quality provider. That's a bad outcome. And they're also being forced to overcome their inherent fear of technology. You know, it's only been about 10 or 15 years since they got fax machines. To actually accelerate spending today on electronic health records. There has been no vehicle in the past to find the money. And that's the issue. So they're spending it on physician connectivity, they're spending it on in-house standardization of order entry, building of electronic medical records, building on their billing, coding, and clinical systems, incorporating best practices. That's what makes me excited about what's going on. And doing social media with patients, getting online scheduling, getting all of these systems is just a matter of time and money. It's no longer a matter of willingness. And that's what makes me more optimistic that we will get to this goal in the future.
It's a very different time we're in now. It seems like a lot of things are aligning. Garri, do you have some comments on that?
Just two quick comments. I think Sheryl's spot on. I do generally think it's different this time, and I don't mean in terms of US healthcare reform. I just mean in terms of building a healthcare business. It does seem that there's a lot of momentum. The second point I would make, if you're going to connect, I should back up and say Circle's the largest partnership of clinicians in the world, I think, outside Kaiser. We've got over 2,000 consultants and primary care physicians in our partnership, so I speak to a lot of them every day of the week. If we're going to connect those clinicians direct to the patient, you need to understand this wave of consumerism that is happening in my generation, the generation above me, and the generation below me, and the doctors have never seen anything like it, to Sheryl's point. And then if you're going to start, to your point, which I agree with, putting the power in the primary care physician's hands, he's got even less specialization than the consultant. So they actually feel very vulnerable. And I think if we're going to open up and disintermediate insurers and all this sort of good stuff, I think that primary care physician is going to need an awful lot of support around him, because it probably is the way to go. But I think this cultural wave of consumerism is probably the thing in healthcare which is not as understood as perhaps other things.
Well, I think there are a couple of points about that, and I want to come back to Sheryl for a moment, at least, is that the information is starting to become available for them to start to walk, talk, and act like consumers. That's point one. Mm-hmm. And point two, the payment reform that's been going on subtly and somewhat corrosively is a large increase in big deductible plans. So now they're paying for it, customers are paying for it out of their own pocket. It's not some invisible bill that goes off the insurance company and I get $20 copay. So now I'm starting to shop for care. And my point being amidst all this is that dynamic is changing and people are getting care from a lot of different places. They're going to the internet, as was brought up, to get a whole list of things that they want to talk with their doctor about in their 15-minute appointment. They're also going to other places like social networking. The caregiver model of the past, where you send in the quarterback to run every single play, the only person to deliver care is doctors, is both expensive and it doesn't work. And so they're looking for, people are looking for, I'm looking for different treatment modalities, different places. And I think Sheryl was speaking about this fairly passionately earlier today about social networking. I wonder if you could.
Well, one of the key areas where that's actually worked brilliantly is with breast cancer patients. They are considered with some fear and sometimes disdain in the medical community because these women are so, and their families are so well informed. Whether it's specific sites related to breast cancer or now it's becoming more social networking type of sites. These are women who know all, who find out what they don't know, who share information about providers, about treatments, about technologies, both domestically and abroad. And it has created not only more awareness among women who are diagnosed with the disease, but more funding. And I think that makes it one of the best case studies of what the power of the internet can do, the power of social networking can do, because if we were each in our discrete little homes, that kind of connectivity within that community and beyond that community could never have happened. And so that's been a tremendous empowerment, and as a result of that, I think we have a lot more money invested in finding treatments and cures.
Constantine?
I think we all have slightly different points of view in this morning that clearly came out. But I think one thing we all agree on is, cost is a problem. It just costs too much to get the level of care that we're getting. Now, but we also have to keep in mind, I'm sure our government has good intentions, but there's a lot of things going on in the background that affect people like us in the medical device business who create the technology that doctors use to treat their patients. For example, medical device tax. The survey just came out 9 days ago from a consulting firm. They surveyed 100 medical device companies, and the unanimous feedback was that it's it will obviously cut their profits, but it will slow down their R&D, which means less innovation. It will take longer to develop new technologies, and those kind of things. The 510K, which is one of the FDA approval processes for approving a new medical device technology, there's reform going on there that's going to significantly impact how long it takes to get a new product approved, which ultimately affects the patients.
And look, if I could just interject, I'm all about innovation, but we have to decide as a society what kind of innovation we get or what we want. I mean, you know, we have fantastic, and we talked about how little energy innovation we have in this country. We have fantastic innovation around sugary breakfast cereals, right? We have decided as a society that innovation on sugary breakfast cereals is a fantastic thing. And likewise, in healthcare, we have a huge amount of innovation, but we have a business model that does not create incentive for innovation to drive costs down and quality up. We get better and better at creating machines to do jobs and procedures to do things, but that treadmill is driving a process which is causing outcomes to get worse as treatments increase and costs to go up. And we need to reform how we construct our business models so we get the right kind of innovation, not just innovation for innovation's sake.
Yeah. Sheryl.
Strenuous objection. But I think there have been major moves to, even at the FDA, and I'm not a big fan of the FDA, but even within the FDA process, to understand the cost-benefit analysis of any new device, of any new drug, any new procedure that gets approved. That's the first thing. I would suggest, for example, that robotic surgery, that the kinds of over-the-wire catheter-delivered heart valve replacements that Edwards Life Sciences is working on, albeit at a very high price. If you're facing an open heart, open chest procedure versus something that's non-invasive or less invasive, and you walk out of the hospital 2 days later with a brand new heart, you know, I don't know how you can say that that's not cost effective in some way, shape, or form when you take into account the quality of life for the patient, as well as the cost of care and the potential complications thereafter. So, you know, I was a fan of, when I would look at the profit margins of a medical device manufacturer versus the losses of a hospital, I would say, gee, I want to take money from there and I want to put here if I'm a regulator. On the other hand, when I actually saw some of what the devices are that are being contemplated and manufactured and realized the implication long-term over the total cost of care over the life of the patient, it's a necessity that we continue to innovate. I'm not saying you do it solely without any kind of cost-benefit analysis, but kind of like that adorable little Tesla that I dearly want. I think there are very clear and very obvious benefits from having certain types of innovation rewarded, and to blanket policy is just inappropriate.
But let me interject one point. I actually don't see your points of view as being mutually exclusive.
Okay.
It's an allocation of resources. But what I laud Nick for bringing out in particular is that, you know, just calling it out, the skunk at the picnic, the model is broken. And we need to focus on that. That doesn't mean we shouldn't continue research and innovation, but for Pete's sake, we've been stymied with fundamental changes in the way care is delivered, and part of it, I'll call it out, is the insurance companies. I've been for 10, 15 years wondering how much longer they're going to be able to make a credible value proposition. What are they contributing here?
That's why we have 40-odd million uninsured. Yeah. They price themselves out of the market.
I don't want to keep Garri in a seat here. So.
I just think this debate about innovation. I know Mark wants to talk about technology, and I think that Nick's point is spot on. Before we start, if you're an entrepreneur or a VC, before you start trying to figure out where you're going to innovate in healthcare, Nick's right. It's the business model has to change, and you need to understand where that business model's going. I mean, just let me give you an example. We're very fortunate at Circle. We're a blank piece of paper, or were 5 years ago. So we build hospitals. Norman Foster's just completed one for us. Great, fantastic. The problem is that hospital building is at least 25 years old. It's going to last me at least 25 years. But as Sheryl will tell you, average length of stay is going down by 6% a year. 20 years ago, 80% of elective surgery was inpatient. Now it's all outpatient. You need to sort of understand where those trends are going. And it's not legislation. It's actually the effect of healthcare and technologies fundamentally changing business models right here, right now, and you've got to sort of adapt to them.
Right.
And that makes it very difficult. And when you layer on the primary care piece, that's the...
But it's not just the primary care piece. It's paying doctors to keep you healthy,
not
if and only if you're sick. And when you pay doctors to compete on the basis of delivering high-quality health care at a low price rather than how much stuff they can sell you, the shape of innovation will change in a very constructive way. That's my point.
Not
that we should slow innovation down. We should just get different kinds.
The interesting thing, Nick, is that's actually how the Chinese healthcare delivery system was designed about 500 years ago. The medicine man was paid when you were healthy and stopped getting paid when you got sick. Yeah. We only have about 2 minutes left. Would ask if there are any questions for people to come to the mic at this point. And again, the byline is we're going to continue this conversation. There's a big subject we haven't gotten into, like culture and the inertia that represents. Questions? Jean.
Your thoughts on the dangers of rushing for the electronic health records to market by fossilizing the current system? Mm-hmm. What are the dangers of our rush to that?
Wow, there's a lot of parts to that.
You want to take a shot, or?
I mean, I think there clearly is a danger of that, but I can tell you in the United Kingdom, there's no danger of it because it's not been a rush. It's going to take many years, and you could argue that's a good thing. We don't worry about it in the United Kingdom too much.
And I'll add the domestic viewpoint on that. 20 years ago, Medicalogic was formed. 10 years ago, Medicalogic came public. 5-6 years ago, Medicalogic went bankrupt. We've been working on electronic health records for a very long time. I think the only difference that exists today is the fact that the federal government has finally more or less created a funding mechanism for it. But I will remind you, it requires that hospitals who are very financially constrained lay out millions of dollars today to get money maybe in 2013. And if health reform is repealed, they won't get it.
Yeah, I mean, there are hospitals in the U.S. that are virtually totally paperless, and they work very well. But as she brought up, the issue is how do you pay for it? Is it implemented properly? And the other issue is industry standardization. There are really not good enough industry standards for the electronic record system.
Well, I'm going to use my prerogative as the host here to finish up the last 10, 15 seconds. Gene, let me take another shot at your question, because I think we've hit parts of it, but I think I understand, at least in the right zip code, what you're really driving at, is the displacement that occurs when you rush to an EHR and give up the fossilized record, as you were calling it. What are you leaving behind? And I'm fond of saying that if you're going to replace something, understand what was there before you replace it, because you may have missed something. It's not a calling or whatever, but make sure that when you move, you're not losing something. So that's one point that I'd like to leave you folks with. We're out of time. Again, I would invite you this afternoon for 3:45 in a spirited conversation, and thank the panelists, one and all.
Thank you.